Our next speaker is Professor Thilaganathan. Professor Thilaganathan is the head of the fetal medicine unit at St George's Hospital in London. He's also the editor-in-chief of the White Journal, and he has a great task to get us through the pathophysiology of preeclampsia and the impact to the mother.
Thank you. First, George.
Okay.
Yeah, John, where did you put my talk?
It's always great to have.
Thank you very much, George. I'd like to thank George Michaelidis and the organizing committee, and also John for finding my presentation. It's a great pleasure to be in Dubai and to be able to speak here today. I've enjoyed the last 2 days I've had here. Before I talk, I need to declare some interests. My main conflict of interest is that I'm editor-in-chief of Ultrasound in Obs and Gynae, which is the leading imaging journal in obstetrics and gynecology. I make no bones about my allegiance to it. If you're interested in imaging and in obstetrics and gynecology, this is a journal to get. We have a lot of free resources, even if you don't take a subscription, but it is where to go if you want information. My major talk today is about maternal heart function in preeclampsia. I understand that most of you will be neonatologists and obstetricians, and therefore there is a need to frame why we need to study cardiac function in preeclampsia. First of all, most of the predisposing factors that we are aware of, advanced age, hypertension, obesity, and family history of preeclampsia, are co-predisposing factors to cardiac disease in adulthood. So the same things that make you more likely to have preeclampsia as a pregnant mother also make you more likely to have cardiac disease. Secondly, at the moment, yes, 6% of women have cardiac complications as a consequence of preeclampsia, and a woman that dies in pregnancy from preeclampsia is tenfold more likely to have myocardial necrosis, which is highly related to cardiac dysfunction. So cardiac dysfunction is 10 times more prevalent in women who die of preeclampsia. What is the epidemiological evidence? Well, this is the number of deaths according to the years after you have a baby, and you can see that whether you have a normal pregnancy or whether you have a spontaneous preterm delivery, there is in the subsequent 10 years about a 1% maternal mortality. If a woman has preeclampsia, it is about a twice increase, so she has a 2% mortality in the subsequent 20 years. But if a woman has preterm preeclampsia, there is a threefold increase in death due to cardiac diseases within the next 2 decades. So there is no doubt that preterm preeclampsia either predisposes to this, cardiac mortality, or that the features of cardiac disease predispose to preeclampsia. Either way, chicken or egg, we're not sure. Finally, most of my basic research is based around the association between uterine artery Doppler indices and preeclampsia. And we know that women who have good trophoblast invasion of their uterine arteries and have very low resistance indices have excellent evidence on a cellular and molecular basis of good trophoblast function and are very unlikely to get preeclampsia. We also know that the presence of very high resistance uterine arteries increases your risk for preeclampsia some 10 to 15-fold. But the reason for my entry into this area was that despite women having severely abnormal uterine artery Dopplers, 80% of them do not develop preeclampsia. So the question we asked ourselves is that if uterine Doppler abnormalities are good indices of placental injury, is it possible that a woman has to have both abnormal trophoblast invasion, so poor placental development, and heart disease for preeclampsia to occur? And that was the beginning of some 3 to 4 years' work in this field. Now, I'm fully aware that most of you are not experts in cardiac disease. John, you're exception clearly. And therefore, there's importance for us to explain why we cannot rely on previous data. And I suppose the most important is the emergence of the importance of diastolic function. And what I was unaware of until about 4 years ago is that myocardial relaxation of the muscles of the heart, is more energy dependent and vulnerable than myocardial contraction. It takes more ATP to get the calcium back in to the sarcoplasm than it does to release it. So the heart in relaxation needs more energy than the heart in contraction. And therefore, it is not surprising that a heart that is under early strain or early stress has features of diastolic dysfunction before it has features of contractile failure. And that will explain why in much older men who are in obvious clinical congestive cardiac failure, only 50% of them will have overt systolic failure when you do an echocardiogram. Half of them will have a normal ejection fraction. How do we explain someone who's got congestive cardiac failure and yet has a normal ejection fraction? The reason is they have diastolic dysfunction. What is also important is that most of the tests we use when we assess women who are 20 or 30 years old and pregnant are designed to assess the heart, a fibrotic heart of a 70, 80-year-old man. Well, it is extremely unlikely that this 20-year-old woman has a fibrotic heart. Yes? Young people do not have fibrosis. The older you get, the more likely you have fibrosis. So the tests we use can pick up fibrotic, poorly contractile hearts, but are not very good at picking up young, non-fibrotic hearts, which have a problem with relaxation. Does everyone understand that? That's a key component of why we fail to investigate maternal heart function properly. What's the other problem? Most of the assessments we do in adult echocardiography are dependent on pulse wave Doppler. That is a Doppler assessment of the blood flow in vessels. And that is hugely load independent, okay? And with the advent of what's called tissue Doppler, that means using the Doppler technique on small parts of tissue rather than the blood vessels, we're able to get a load-independent assessment of myocardial function, which is a strong predictor in adults of later cardiovascular morbidity. In fact, tissue Doppler indices are the best assessments of long-term cardiovascular morbidity in an adult. Finally, most of the previous studies failed to correct for changes in preload, that is volume. And most of us as obstetricians know that a woman's circulatory volume changes by some 40 or 50% in pregnancy. And therefore, we were using indices that presumed the woman had the same circulating volume, when in fact her circulating volume changes a lot. And finally, we were using cardiac output and total vascular resistance as indices because in a 70-year-old man, his weight doesn't change very much. But in a mother, there can be huge changes in weight, and it is important to use indices that are corrected for changes in weight during pregnancy. So what do we do? And I mean, that's not the end. There are many, many features for why cardiac function tests in the past were poorly negotiated. So the basis of our test was to use state-of-the-art tissue Doppler imaging, which is load independent, along with strain and strain rate imaging, which is looking at myocardial function rather than chamber function, to combine it with standard tests and to use a comprehensive approach, not just to look at single indices, but a global assessment of the mother's heart function. So the summary of that is that up till now, most tests have had weaknesses, and most assessments and studies have had weaknesses, and it is important to use modern day techniques and to understand that diastolic failure is important. Before we go on to look at the results, it's important for us, because I'm an obstetrician, not a cardiologist, to understand how we actually classify poor heart function. And John, please excuse the comic slides, but there are 3 ways in which we assess how the heart works. The first is called remodeling. That means when you go to the gym and you work out, you get this sort of concentric hypertrophy. Most of us would agree, and please excuse the pictures, but that this sort of hypertrophy is adaptation and a good change. But as you work out too much, most of us will agree that this is eccentric and not a good form of adaptation of the muscle. So the first way in which we can look at the heart adaptation is to see whether the remodeling of the heart is adaptive and good or counterproductive and ugly. Everyone got that? So we look at the remodeling of the heart and say, is it concentric hypertrophy, which is responsive to the extra work of having increased volume in pregnancy, or is the heart eccentrically developing and therefore maladapting to the changes of pregnancy? The other 2 ways is by looking at myocardial and chamber function, or ventricular function is the same as chamber function. And it is important to distinguish these 2. Myocardial function is the function of the individual muscle segments here, whereas chamber function is an overall assessment of the chamber, which, yes, has to come after myocardial dysfunction. So as the heart gets compromised, first we have impaired myocardial relaxation, which as it progresses leads to impaired myocardial contraction. And as the heart then worsens, you first get chamber or ventricular diastolic dysfunction. And diastole, remember, is about relaxation. So in order to get diastolic dysfunction, one must first have myocardial impaired relaxation. So this is the ladder through which the heart progresses until finally, this is what a 78-year-old man gets, which is chamber systolic dysfunction, where the ejection fraction is affected. So the questions we asked ourselves is maternal cardiac function altered prior to the onset of preeclampsia? And what we did was we assessed maternal cardiac function in mid-pregnancy in normal women and those who then later developed preeclampsia. We studied 231 women who were at high risk of preeclampsia, but they were all normotensive, and of those, 28 women developed preterm preeclampsia and 40 women developed term preeclampsia. Remember the 3 ways in which we do it? First, we looked at remodeling. And what we found is that this is normal pregnancy. 10% of pregnancy had normal remodeling. Women who developed term preeclampsia, 23% of them had remodeling. But 60% of the women who developed preterm preeclampsia had remodeling. Yes? So this is 3-fold higher than the women who had term preeclampsia. When we looked at myocardial, this is the muscle function, not the chamber function. Again, the same thing. No difference between controls and term preeclampsia, but again, 3-fold higher abnormalities in myocardial function. So myocardial impairment precedes ventricular diastolic function. So what was ventricular function? When we looked at ventricular function, again, no difference between preterm and term preeclampsia, but 4-fold higher diastolic dysfunction in women who develop preterm preeclampsia. So what do we find? That at mid-pregnancy, women destined to develop preterm preeclampsia have more remodeling, impaired muscle relaxation, and ventricular chamber diastolic dysfunction. Now, it's not entirely conclusive whether this is predating the pregnancy or whether it is an extremely early response to preeclampsia. We went on to study women who actually develop. What happens at the time of when you get preeclampsia? So this is not at 20 weeks, but when the woman presents with preeclampsia. We distinguish them again into preterm and term because short-term outcome, maternal mortality and morbidity risk for preeclampsia before 32 weeks is 20-fold higher than at term. So clearly there is something much higher risk of preterm preeclampsia, and I don't need to explain that to the obstetricians. But long-term also, there is an 8-fold higher risk in preterm preeclampsia than normal pregnancy and threefold higher than in term preeclampsia for long-term cardiovascular risks of mortality and morbidity. So what happens at delivery? Again, we looked at 27 preterm, 50 terms, and 100 controls, and using the same assessments of remodeling, geometry, muscle function, and chamber dysfunction, we found that remodeling was present at delivery in the equivalent numbers, but there was severe hypertrophy. This is the Arnold Schwarzenegger in 1 in 5 women with preterm preeclampsia. Similar levels of impaired relaxation, but impaired contractility was present in 40% of preterm preeclampsias. Similar levels of diastolic dysfunction, but this was a shock. 25% of women with preterm preeclampsia have overt systolic dysfunction. So this is the model and the summary of what happens before you deliver. In a normal pregnancy, there is increased volume, there is some remodeling, there is changes to the heart, and the tissue Doppler indices are indicative of some myocardial damage in women with 70 to 80% of term preeclampsia. The problem is that in 20 to 30% of preeclampsia, the increased afterload leads to eccentric hypertrophy, increased wall stress, and tissue Doppler indices indicative of ischemia and fibrosis in women who develop preeclampsia, and that's in a third of women. So the $64,000 question was, what are the postnatal consequences? And in order to study that, why is it important to study that in the first instance? The global burden of hypertension is 7.6 million deaths per annum, 50% in people with pre-hypertension, 50% in young women, and 80% in low and middle income families. But what is not highlighted here, but should be present there, is that even in this day, even in the developed world, women are 2 to 3 times more likely to die of cardiac disease than men. There still is a huge health inequality in cardiac disease amongst women. And the reason for that is that they present with a silent type of cardiac morbidity and mortality. So when we looked at it, we looked at 27 preterm women and 37 term women, and we followed these women up for 2 years after their delivery. If they developed hypertension, they were excluded from the study. These are so-called normal women who had term and preterm preeclampsia. And what we found is that at 2 years post-delivery, the women who had term preeclampsia, this is 2 years later, were no different to the controls. But 40% of women who had preterm preeclampsia still had altered remodeling or geometry in their hearts 2 years post-delivery. Myocardial function, 50% of term women and 3/4 of women with preterm preeclampsia had impaired myocardial relaxation 2 years post-delivery. And finally, when it came to ventricular function or chamber function of the heart, term preeclampsia was the same as controls, no significant difference, but 50% of women with preterm preeclampsia had persistent ventricular dysfunction 2 years after delivery. These women fit into what's called stage B, that is asymptomatic heart failure. 50% of them having stage B asymptomatic heart failure is equivalent to 60 to 70-year-old men and women. So women with preterm preeclampsia 2 years after delivery have the same kind of myocardial and chamber function as 60 to 70-year-old men. When we looked at the rate of development of essential hypertension over 2 years, in our controls it was 1%, in our term preeclampsias 1 in 8 developed essential hypertension 2 years postpartum, in our preterm preeclamptics 40% of them developed essential hypertension within 2 years. So in conclusion, women with preterm preeclampsia have persistent myocardial and ventricular dysfunction postpartum. The majority of preterm preeclamptic women exhibit stage B asymptomatic heart failure. That's 50% of them. That's the same rate as 70-year-olds. Preterm PE and stage B heart failure predispose to the development of essential hypertension, and that these findings above may explain the increased risk of cardiovascular morbidity in these women and women in general, and present an opportunity for early intervention that may modify their cardiovascular risks long term. If any of you are interested, these two current opinion review articles will summarize that. Thank you, Joe.